Good afternoon, Beth. Thank you for joining me on the podcast. I'm so excited to have you on.
Thanks for having me. I'm so excited to be here.
Yay! Oh my gosh, I'm so excited to talk about all the important, juicy stuff that we're going to get into today. But before we get into all of that, let's have you share a little bit about yourself, your background, how you got into the airway myospace.
All right. I am retired from clinical hygiene, but I was a hygienist for 35 years. And I found out about orofacial myofunctional therapy in like 2016, maybe, but it wasn't until 2018 that I actually took my first course in Chicago from the OMT. And in the first 15 minutes of that class, I realized that the dental fear that I've been talking and writing about for 20 years, I'm like, oh my God, it's the airway. So I understood that, that dental anxiety is a post-traumatic reaction, but I never could pinpoint the initial trauma. And now I'm like, duh, they can't breathe, and so the person can't breathe, they're traumatized, and then future appointments are post-traumatic episode. So that was like, so my certainty is my philosophy of practice, and I came up with that over 20 years ago. Serene dentistry, because I understood even back then that if I understand why patients are behaving the way they do, that I can approach them with serenity, serene dentistry, surdentity. And when I'm serene, I have the much better chance of my interaction with this person also being more serene. And I see so much suffering on both from patients and from professionals. Professionals are frustrated by these uncooperative patients, and patients are traumatized by these uncaring professionals. And it doesn't have to be that way. So
Absolutely. And, I know we were chatting a little bit off air before we started recording. And I think both of our passion projects are, again, getting to hygienists to be able to assess for and refer properly for these airway related issues, because
mm-hmm,
we see patients literally
mm-hmm,
the most out of any medical provider.
mm-hmm,
Let's kind of dive into that and just talking about, first, I guess, why it's so important that, I mean, all dental professionals, but again, both of us being hygienists coming at
mm-hmm.
that aspect, why is it so important that we're, able to spot these signs? And then we can kind of get into what are the most common signs and symptoms that hygienists can
Mm-hmm.
start to look for?
So, these airway signs, once I understood what they were, um, like your myo eye, oh my God, now I can't not see it. And
Mhm.
I realized that these patients that are being labeled as uncooperative, if you observe them with a myo eye, you will see these people can't breathe. And
Mhm.
we'll talk more about that in a few minutes about what exactly to look for. But these uncooperative dental patients and these airway patients, they're the same people.
Mhm.
And that's why it's so important for hygienists to understand that. We're the ones that are seeing patients the most frequently. Even if Mr. Jones only comes in for a cleaning twice a year, you know, we're still the ones that are seeing him most often.
Right.
And we're the ones that have the opportunity to recognize these signs and symptoms and let Mr. Jones know, you know, let Mr. Jones know two things. First
Mhm.
of all, you're not a bad person. You're
Mhm.
not a bad dental patient, and your dental disease is physiologic. It's not a moral failing. And also, these these things that are contributing to your dental disease are also contributing to your general health. And I would love to be able to help you with both of those things.
I love it. And I think it's so important too that hygienists, dental professionals understand that this assessment process literally begins before you're even seeing the patient, right? Like reviewing that
Absolutely.
medical history. So if you want to talk a little bit about that, that'd be awesome.
So these signs and symptoms. So you and I know as as myo people, that when you see somebody with a forward head posture, okay, and you can see they're in their facial structure, they have a flat upper lip or hardly any upper lip, or they have a, their lips are up like this, right away. And we know the signs of a deficient maxilla, right? We know the outward signs of a deficient maxilla. So when I open the door to the waiting room and Mr. Jones is sitting out there and he's all mad, instead of feeling sorry for myself that, oh God, this guy, let me take a step back and look. Oh my gosh, Mr. Jones has a thick neck. He has no upper lip. He's got forward head posture. Mr. Jones is a mouth breather.
Mm-hmm.
So when I try to work in Mr. Jones' mouth, his brain's like, hell no. The brain doesn't care. And I think a lot of dental people waste a lot of time getting angry at patients for these behaviors that are based in airway protection. I told my patients all the time, your brain doesn't care, okay, what I have to do, how important it is, whether it's I'm legally required to do it or not. If I come at somebody who can't breathe with a bunch of legalistic terms, it's not going to go well.
Right.
And if I come at them with some sort of way to force them to do what I need them to do, it's not going to work. It's going to become a power struggle.
Right.
But
Right.
when I say your brain needs to breathe and I'm going to make sure that you can breathe, and all of a sudden it's like, oh, okay.
Yeah. Like, thank you.
Like patients that refuse x-rays, the vast majority of people who refuse x-rays refuse them because they are mouth breathers. They can't breathe. And and you can be proactive. A hygienist can be proactive with that. Look at their previous x-rays. Is the occlusal line slanted? Can they not get past the second molars? That, boom, right away, that's going to let you know this person has a hard time with x-rays. And that way, when you ask Mrs. Smith, when you tell Mrs. Smith we need to take x-rays and she says, well, I don't want them, instead of like getting again into a power struggle, let's talk about, well, you know what? Let me look in your mouth. Oh my gosh, you have these big bones in the bottom of your mouth. No wonder you hate x-rays. And, I'll bet you feel like you can't breathe when I take these x-rays.
Mm-hmm.
I'm going to work with that with you. And like all of a sudden, like, oh, okay.
Yeah. And I love how you said before, like referencing the myo eye, like just kind of looking at it from a different perspective,
Yeah.
because we're all guilty of it, right? Like you see Mr. Jones or Mr. or Mrs. whoever that is due for a full set of films, and you know that they have a severe gag reflex, and like that is the last thing that you want to be dealing with that day.
Right.
Well, what are they dealing with day in and day out that this gag reflex is screaming at you? Like, hello,
Yes.
right?
Yes.
So let's talk, if you can talk about a few other ways that airway issues might manifest during routine, dental procedures that, professionals might see that can kind of just like alert, like, okay, like I need to look at this. Like there might be an airway thing going on.
Well, the gag reflex, a patient with a strong gag reflex, automatically that person is a mouth breather. Nose breathers, as a matter of fact, I was able to come up with a breath coaching technique to help patients get through dental x-rays using the breath. And it works most of the time, because I realized that the gag reflex is about the in breath. Okay, if a patient can't get a breath in through their mouth, they're going to gag. So when I have them breathe in through the nose and hold the breath, the brain's not looking for that breath in, and they're not going to gag. So the gag reflex is automatic. And when you're doing your orofacial cancer, your orofacial screening, you can look at, we know these things. If you see the shiners, under their eyes, if you see a dry lips, chapped lips, averted lips, these are all indications that this person is using their mouth to breathe. And a person who's using their mouth to breathe is not going to have a good time in the dental chair, because we are working in the mouth. So even before, and then, and looking at their medical history, look at what medications they're taking. These are also indications of, that this person is you know, the like diabetes and other things, they start with mouth
Mhm.
breathing.
Mhm.
So again, you can, it's all like a heads up.
Yeah, and I love Dr. Lamberg's book. What is it? Treat the cause, treat the symptom, I think it's called.
Yes, yes,
Because again, like it's always nice to have resources to refer patients to. And it's like, I love how he has it divided, like in his Lambert questionnaire, like divided by medical
yes,
conditions and then,
yes.
the correlation between sleep disordered breathing and that specific medical concern. And I love having that as a resource for patients
Yeah.
because, again, sometimes in the hygiene chair, like maybe all we're doing is planting a seed, but we're something's there that wasn't there before. Like maybe they're not like, yeah, let me go do all the things that you want me to do. Maybe not, but you planted that seed. They leave for the next 3, 4, 6 months. They think about it, and how many
Mm-hmm.
they come back and they're like, you know what, Beth? I recognize now that I am a mouth breather. You're right. I do
Yes.
wake up in the morning and my mouth is very dry. Uh,
Mm-hmm.
so that's why those conversations, like I think sometimes hygienists get discouraged that like they start to have these conversations and maybe they're not seeing the response from patients that they want, but sometimes it
Right.
takes time, right?
It takes a long time. And especially, hygienists have been trained over many, many years to, talk about plaque and teeth and flossing. And, that's what, and patients come in and that's what they're trained to listen for. So when it was actually kind of cool when I would start talking about, did you know that, your skull's not big enough. I used to have on my computer the picture of the ancient skull and the modern skull. I'm like, this is what we used to look like. Okay. This is what we're like now. Okay. And I'm trying to put x-rays in that. What are you kidding me? So, you know, being able to start the conversation there and bring it around to, this is why, we're ill, right? Because we're living the
Right.
opposite of what we're built for.
Mm-hmm, mm-hmm.
And in the dental, in this orofacial complex, it's no different. We're eating soft foods, we're breathing with our mouths, and the mouth is trying to keep your mouth healthy within that context is difficult at best.
Yep.
And just being compassionate, like I
Right.
get it.
And that when you just brought up like eating with diet and softer foods and whatnot, it just just started. Well, I shouldn't say just started. It's been 2 months now, but we started baby led weaning with our twins. And my mother,
Really already? Oh my God.
they're going to be 8 months next
Are
week.
you
I
kidding
cannot.
me? They're
I
that
know.
old?
I don't know how they're that old. Isn't it
Oh my
wild? I
God.
feel like I just popped them out.
Yes.
But my mother thinks I'm absolutely crazy because anybody that's done baby led weaning, it is very messy because you let the
Oh yeah.
baby
Yeah, yeah.
away. But I'm like, it's just so important, right? And
It
she's like,
is.
do
I'm
they
so
ever have those pouches? And I'm like, no. I mean, maybe on
no.
occasion, like if we're out and we need to, but like, no.
Mm-mm.
Like
No.
whole cooked foods. And it's so awesome. So we started, yeah, I think it's been almost 2 months. So we started at 6 months. I did do 2 weeks of purees just to get them used to like a little bit of a thicker,
Mm-hmm.
formula or whatever before we started like actually baby led weaning. But we've already tried 30 new foods in these 2 months. It's been so cool and just so fun to watch them like navigate it. And I started them on their munchie already. So like it's cool for me now
Yes.
to like see everything that I talk about on a daily basis and like actually live it from birth. You know
That's
what I mean? And
amazing.
like,
You need to write a book about that. Okay. You need to be
yeah.
documenting all of this because it's going to be very, very helpful for future mothers.
And what I shouldn't say that I want to have a research study on my children, but so both of the girls were tongue tied, lip tied, cheek tied. Sierra is nursing. Peyton, unfortunately, we tried nursing for a very long time. It wasn't working out. And then it got to a point where like mentally I was capped, she was capped. So she is bottle fed. So I'm even
Mm-hmm.
interested to see the way that they develop, one being nursed, one being bottle fed.
Yeah, like Dr. Mew's study on the twins.
Yeah. So it's going to be, I mean, now again, I'm doing a lot of things to help counteract what might happen from the bottle feeding with Peyton, but it'll be very interesting to see. So in like another 5 years, we'll have to come back on and do another episode and see,
Absolutely.
right, how far they've come. But
Yes.
I just went on a total tangent there. But when you brought that up, we just fed them butternut squash before this episode, and my mom's like, We're gonna literally hand them these pieces of butternut squash," and I'm,
Yes.
yeah,
That's so awesome because yeah, and you're not only when you spoon feed a baby, you are training them in a tongue thrust swallow
Mhm,
because the brain is going to protect the airway, and that's the tongue's job is to protect the airway. So you put a spoon in their mouth, and the tongue is gonna come
mhm,
up to protect the airway. So
mhm.
good on you. Very proud.
You.
Very proud.
Thank you. Thank you very much. It's a little stressful. I'm not gonna lie. And I know
Yeah.
that like the gag is there for a reason. The gag is there to protect them from choking. And I know all of
Mhm.
that. But the second that I see any kind of,
Oh, right. Oh my
I'm
God.
freaking out.
Yeah.
I'm freaking out. I have my little life suction saving thing next to me at all times. My anxiety's like through the roof. I'm sweating.
Absolutely. Absolutely.
Um, okay, anyways, let's get back to the patient in the chair who has an
Yes.
airway issue. What about well actually before that, before I ask this question, which hopefully my mom brain remembers it, what I wanted to say was I feel like hygienists also like I find a lot of hygienists are interested in learning more about airway. They get the connection, they understand it all, but their concern is like I've been in this practice for 20 years, and now all of a sudden I'm going to be talking about all this new stuff. And they get a little nervous, like, they don't want to come off like salesy by any means, or like,
Right.
oh, I took this new course. Now you know what I mean? So,
Right.
I guess how long were you practicing as a hygienist before you learned all this airway stuff? And then how did you start those hard conversations? Because I mean, my advice to people, I'm like, just be honest. Like,
Hmm.
know this then, but we know it
Right.
now, and it's our job to share it with you.
Right. I graduated from dental hygiene school in 2000 in 1988, and I took my first myo course in 2018. So that's a lot, you know. So look at how long I was practicing, even knowing about and even understanding about post-traumatic stress disorder,
Mhm.
but not putting it together. So
Right.
look, yeah, all those years I was practicing, when I think about all the gagging patients I saw for all those years and trying to, get them to take x-rays and all you know, the struggles,
Yeah.
it makes me sad that I didn't know what I didn't know.
I know. I think about that all the time too. There's always this one specific gentleman that comes to my mind, and I sure hope he's still alive. But he would come in or he would call. I swear to God, it was almost like once a week. And he'd call and we'd see his name come up on the caller ID, and all of us would be like, what was he chewing on this time? Like how he broke
Mm-hmm.
another crown, like what's going on? Was
Mm-hmm.
he chewing ice? Was he chewing rocks? And it's like, and I look back and I can still see his mouth. I can
Mm-hmm.
see nutrition. I can see the tongue that looked massive, but really it's trapped in
Yep.
a small cage, right? And
Yes.
nobody's ever asked this man how he sleeps, how he
Yeah.
breathes.
Right.
And, so I always have those moments where I think back to all these patients and it's like,
Yep.
oh my gosh, I wish I could go back and change it all, right?
Mm-hmm.
We know what we know now, and now we just do better.
And once I had that knowledge, it was the most natural thing in the world to want to share it with my patients. And
Mhm.
I never felt preachy. They were fascinated.
Yeah.
So patients they were like, "You're kidding me. Wow, that makes so much sense." So
Mhm.
I never felt like I was trying to sell them anything.
Right.
Um, and I was working in practices that were not airway centric.
Mhm.
So, it was my job to help these people understand how, about the importance of nasal breathing, and
Mhm.
to, when you go home, look at this. I had like the oxygen advantage in my operatory, just
Mhm.
to, let them know that there is information out there. So I'm just, I was not, of course, obviously I don't have a problem running my mouth. So, to me, once I had that knowledge, it was the easiest thing in the world to
Mhm.
share it with the people in my care.
Well,
So,
like you said it, like you said, it made sense to them. And that's the thing with airway stuff, right? Like it
yeah,
makes sense, like it just clicks. And so
yeah,
I don't think that many people are going to doubt what you're saying. It's almost like, And I'm sure you've heard this so many times, like, these patients go to see whatever medical providers and they don't get questions answered, right? Like there's no explanation as to why. It's like, let's just put a Band-Aid on you.
Yes.
So they're probably so thrilled to now have you be the one that's taking the time to explain why they are pressing snooze on their alarm 18 times in the
Yes.
morning.
Yes. And why, I loved explaining, bruxism and recession and abfraction. I'm like, look at when you're grinding your teeth, you are eliciting the same response that allows your permanent teeth to come in underneath your baby teeth. Okay. The bone and the teeth roots feel pressure. They don't know the difference between bruxism pressure and erupting tooth pressure. They just know pressure. So that they start to, the roots start to, their osteoclasts break down the bone, and whatever the clast is for the root, I can't remember, odontoclast, start breaking down the roots. And that's why your gums, first the bone recedes and then the gum, first the bone recedes and then the gum recedes. And, they were like, oh, yeah. I'm like, you're not removing your gum tissue with your toothbrush. This is why this is happening. And it was great because then they were like, oh, okay.
Mm-hmm.
I loved it.
What about let's talk a little bit about like the correlation between TMD patients and myo patients and like the
Mhm.
dysfunction that is typically present with TMD patients.
Yep. So, and again, I didn't know what I didn't know, but I'm
Mhm.
trying to understand. I'm like, look, the most important thing is the airway, and your teeth are the caboose on that train. Okay. The train starts with the brain. The brain is going to survive. In order to survive, the brain has to breathe. Therefore, your brain is manipulating the muscles, okay, that comprise your airway. The muscles are attached to the bone, which is here, and then the teeth are inside the bone, just trying to find some place to go.
Mhm.
And so your brain is shoving your mandible forward to open up your airway. And your mandible is trapped, just explaining all this to it, right? Your mandible's trapped behind your maxilla. Your jaw joint is worn out because you're overusing it.
Mhm.
We don't chew enough and we're grinding the crap out of our teeth. So
Mhm.
your poor joint.
It's so interesting because I feel like when you go and do lunch and learn, say at practices,
Mm-hmm.
whether it's like general, ortho, whatever. And I find at least in my area, it's like people, they're not airway centric, but it's almost like they want to be, like they want to refer for myo and they're like, well, tell me, like, just make it easy for us. Like, what types of patients should we be sending to you? And like, if I'm in an ortho office, I'm like, any
Everybody.
patient that comes and
Yeah,
sitting in your chair.
everybody. Yes.
And like even those like the TMD ortho sleep, it is all one patient.
Yes.
It is all one and the same.
Yes. Right. And, patients, yeah, who do I send to you? Anybody with TMD, right? Anybody with that's using a CPAP,
Mhm.
anybody there's two huge sources right there.
Right.
Um and then who else, like, that they would,
Bruxers, I mean, I would say
yeah,
Bruxers.
yeah, somebody who's a
Typically
bruxer,
TMD
even if they
patients,
don't
but
have TMD, but if they have a lot of wear on their teeth, if they're wearing through night guards, there's
right.
a reason that they're bruxing their teeth. And that again, so TMD, bruxism, sleep apnea, sleep apnea diagnosis, people who are using a CPAP, there's three.
Right. And think about how many of those, like if you're a hygienist listening to this and like tomorrow morning you go and you prepare for the day and you review your patient load, probably out of your 10
Yes.
patients maybe that you're going to see or however many patients you see, are going to have some kind of airway issue.
Yes.
Are there certain screening tools or assessment tools that you recommend that dental professionals use?
um the without it depends on what the practice is looking for. If they're looking to treat sleep, right? Then I'm sure they have all the stop bang and the questionnaires.
Mm-hmm.
A hygienist who is just looking to make a general assessment, I would say to look at the back of their throat, right? When they open their mouth, what do you see? If you don't see the uvula, that's a really good indication that that their airway is blocked. A patient who has a lot of tori, a patient who has bruxism, abfraction, recession. These are all the different signs that this person has an airway issue. If their lips are dry. So these are all things you can make note of and, make little notes, even if, so just for that appointment, you can make little notes. And then down the line, so if you hear this podcast today, tomorrow you go into your office and the 8 out of 10 patients that have an airway issue, you just make little notes, right? Maybe you're not ready to do anything about it, but you can be aware. So you have that awareness. Then the next time that patient comes in 6 months, you'll be like, oh, okay. And now I know more. And, maybe in 6 months, you could be like, oh, hey, Mr. Jones, I remember last time I saw this and I'm seeing it again today. I think you might benefit from a consultation with a myofunctional therapist.
Yep. What about, are there certain products that you would recommend a hygienist learns up on that they can, recommend to their patients? Are there any products that come to mind for you that you love?
For myo?
Or just like for example, like clear nasal spray or something.
Oh,
For
yes, clear
or like
nasal
sleep
spray.
aid or something.
The mute nasal dilator. So those are two good basic things to to recommend straight out of the gate that are going to help with their breathing. If a hygienist is just barely into the airway realm, and there's a ton of products out there all the time. All these, it can get overwhelming.
Oh gosh, yeah.
So I would say for hygienists who are very new to this airway thing, so something to clear the nasal passages, and the clear is my favorite, the xylitol nasal spray, and something to open the nose, like a mute nasal dilator or a breath right strip. I think those are two really good things to start with when you're just very starting out. Talking about the importance of learning how to breathe with your nose and clearing the nasal pathways. And as as hygienists, as you become more astute in your airway knowledge, you can start to expand your knowledge base and become more acquainted with with different products. But it's difficult. Sometimes it can be easy to look at, oh, let me see this online, and then I saw this thing online, and let me tell Mr. Jones about it, and then Mr. Jones has a bad time with it. Then it's like,
Right. Yeah, you definitely want to read up on whatever it is you're
right.
recommending. And what about is there, if I were to ask you your favorite case that you've treated as a myofunctional therapist, is there one specific case that comes to mind?
Oh, I had well, when I was seeing people in person, I actually went and took a little course on manual manipulation.
Ooh.
And so I was seeing patients at a chiropractic office. And so they would come in and we do, the exercises, we do our photos, exercises, and then I would have them get on the table and I would literally do this manipulation. I would pull their tongue out. I would use a 2x2 and press up and pull it out. And, and I would just hold it there. And the couple patients that I did that for, they had They had beautiful releases with
Mhm.
beautiful healing. And this one woman I'm thinking about, you know, the beginning and the end photographs, the difference, she didn't even look like the same person. I mean,
Yeah.
the difference in her profile, in her facial structure, the symmetry, the, you know, the disappearing of the bags under her eyes. It's just like, wow.
Mhm.
I also had this one guy that came in, and God bless him, he was really suffering. Um, he had gone to, he had his, so he had front teeth that had a big space, right? So they fixed the space, but they retracted his
Ugh.
incisors. So all of a sudden he's got all these airway problems. And but he was going to all these dentists, orthodontists, and they're all like, you know, dismissing him.
Right.
And he finally went to a TMJ uh, guy specialist, who, that's how he found me. And you
Mhm.
know, basically the attitude was, sorry dude, you're crazy.
Mm.
And so when I saw him for the first time and we did our evaluation, I was able to explain to him, you're not crazy.
Mhm.
Okay, this is what's happening. And then the very first appointment I had with him, where I put him on the table and I was able to do some, he was like, he fell asleep.
Oh, that's lovely.
And this guy had terrible sleep apnea. And
Yeah.
he's like, that is the most relaxed I felt. And I can't even tell you how long.
Oh my gosh, that's amazing.
Isn't it? Like, oh, that
Can
was
you
a,
explain a little bit for the people that are listening that aren't yet in the myo space, that maybe they're questioning like why is the body work component important? Like, can you talk a little bit about what like how it's connected? Why is body work an important component of like a myofunctional therapy plan?
well, when, so form follows function. So what we do with our body um, dictates how our body is shaped. And okay, I just lost my train of thought. So form follows
That
function.
happens to me so often.
Oh, please. Um, so when we're talking about changing the function, we have to help the form to change,
Mhm.
because the form doesn't want to change. But it all starts with the brain and the airway.
Mhm.
It all starts, so everything that we're doing, the whole body is compensating for this lack of an airway. And that's why people have twisted posture and you know, and scoliosis and lordosis. And so as we're changing the function, the form needs, a lot of times, needs help to change.
What about, is there any like advice that you would have for somebody, whether it's a hygienist, dentist, anybody in the dental arena that is like becoming more interested in being a bit more proactive with airway? What advice, would you have for them? Are there any resources that you would direct them to?
Um, there's geez, when I was taking my training, there wasn't a lot of options. Now there's like,
Mhm.
don't you have an intro course?
I do. I do. Yes. Yep.
So yeah, take yours. I mean,
Well, thank you, Beth.
but I got my initial training through the AOMT.
That's
And
where my initial training was too.
yeah, so I was very happy. Well, I wasn't happy with their follow-up. I got a good education for 4 days, but once I got home, I'm like, so you know, I took another intro course through the Colson Institute. And
Mhm.
that was also, and Sandra Colson is a really good friend of mine now.
Mhm.
So that was also great. But so that's your first thing. But what I love is that there's more and more opportunities to, for people like us, right, who took that course and then didn't know how to act. And
Mhm.
you know, getting involved with Airway Circle or the International Association of Hygienists, or some other group that's going to help you, mentor you in
Right.
you know, moving forward with this knowledge.
I think back. So when people reach out to me, like people, I always say to everybody, there's so many options out there for introductory courses now. My biggest piece of advice is to always connect with the instructor, because I think it's important that you have a good connection, that you can kind of
Yeah.
vibe with the person, because you're going to be learning a heck of a lot of information from them.
Mm-hmm.
And one of the big concerns that I sometimes hear, because my course is virtual, it's all on demand.
Mm-hmm.
People are like, well, I'm a better learner in person. And I can understand that. However,
Mm-hmm.
coming from somebody that did learn myofunctional therapy in person, what I would have done to be able to pause Joy Moeller,
Oh,
listen to her,
absolutely.
slow
Yeah.
her down, be able to take
Yes.
notes.
Yes.
Like I say to them, like, look, it's a lot of information. You are going to have access to all of this for as long as Dropbox lives, which I am sure is
Right.
going to be forever. You can
Right.
go back to it. You can watch the course a second time. It's like watching a movie for the second time. Like, think about how much more you pick up on. I'm like, what I would have done to be able to have that,
Yeah.
after taking, I am so blessed and grateful for the AOMT and getting my journey started into Myo, but it is a lot to put
Oh
into
my God. Yes.
our
Yes.
brain in
Yes.
those 4 days. So I love that a lot of these course options now have that option where it is on demand. So for anybody listening, if you're nervous that you're more of an in-person learner, I promise you it's going to be invaluable to be able to have these resources to go back to. And again, it doesn't
Yeah.
have to be mine. It can be any other course.
Yep.
Don't let that stop you. And I think too, the biggest thing and tell me how you agree, if you agree with this, like when you first became a myofunctional therapist, um, don't you feel like you just kind of have to jump in? Like that's really where you're going to gain the most experience, like
Mm-hmm.
actually seeing patients.
Yes. Yes. So I work with Primal Air. Shirley Gutkowski came up with this amazing idea that, to help hygienists like me who needed to see patients, and provided a way for myself and my colleagues to see patients virtually and learn about seeing patients.
Yep.
Um, so I think that it is, you know, yes, you have to just start seeing patients. But if you're, as soon as you come back from your myo course, you can you'll have your myo eyes. So you can start to notice right away, like, oh, wow, and I know for me, when I came back, I was all so hyped up. But yeah, you can't imagine that.
Yeah.
But in the office I was working at, they were like, well, that's nice, but it wasn't going to be, they weren't going to branch out at all.
Yeah, yeah, and that's okay, right? Sometimes I feel like
Yeah.
that's how we are kind of almost in a way forced to grow a little bit, because if you can't grow in one spot, it's good. And you are so obviously, I was the same way, very passionate about all of this. And I worked in one office as a hygienist. My first full-time job is the job I was a hygienist at forever. And I love them dearly. They're literally my family. They've come to see my babies. They were at my wedding. I talk to them still
Mm-hmm.
all the time, but not an airway centric office. And it got to a point where I felt like I was living this double life. And that's
Yeah.
when I was like, okay, like if you're going to grow and you're really going to do this, like you got to jump ship here.
And when I came back, I hit the streets in Rochester. I was going to, offices, orthodontic offices, and nobody was like, they're all like, oh, that's great, but nothing. So, another girl came along after me, and she's actually done much better than I was able to do, um, in terms of getting referrals, getting people to refer. So, but it takes a while. It takes work. And
Mhm.
I think she's got more discipline than me. I have a lot of passion, but discipline isn't always, the follow through is always not always.
I think that that's an important part to talk about, because I think sometimes like hygienists are led to think like, take this myofunctional therapy course and like, that's it. Like you take the course and now you're going to have all these patients rolling in. And
Right.
it's
No.
not, and look,
Yeah.
sometimes it happens for people. Like I feel like if you live in a very, like if you're in the Boston, like a metropolitan
Well,
area.
yeah. If you live in a city, if you live in
Right.
California,
But like and I think that it's important that hygienists know it is going to be work. And that's where, some people like maybe you don't want to own your own business, and that's great, but you can work for a well-established myofunctional therapy practice and
Mm-hmm.
still be able to utilize those skills, have your independence. Like I
Yep.
have, so my practice, I have 4 in-office therapists and 2 virtual therapists. And in the
That's
beginning,
amazing.
thank you. Yeah, it's super, and they're all fabulous. I'm so lucky. I have such a great team. I've been able to take a step back, having my twins, and they're just rocking it and killing it, and I love them. But it is a lot of work. And some of the ladies, they're like, look, like I didn't realize how much you do a lot. Like it took a lot for you. And I'm like, yeah,
Mhm.
it took a lot of time
Yes,
and
a
hours
lot of
where
time.
you're not getting paid, right? Like you're out there,
Nope.
20 doors are getting closed on you, and maybe one door is
Yep.
getting open. But
Yep.
so not everybody has, that mindset, and that's fine. But also don't let that stop you from taking a myofunctional therapy course, because you can work for somebody else, right? And still
Right.
be able to provide this life-changing care to people.
I would love to create an in-between kind of course. Um,
Yeah.
not orofacial myofunctional therapy training per se, but airway for hygienists. I would like, as a matter of fact, I want to work this out with the IAH, a little certificate for regular hygienists to understand about airway issues so that they can, recognize, respond, and refer. It doesn't make you a myofunctional therapist, but it does elevate your
Oh yeah.
skills. So, something in between. And another thing, so I was at the Myosphere,
Mhm.
uh, and we have to stop with this speech versus hygiene. Okay. Because what we have the opportunity to do right now, I said, speech and hygiene are like chocolate and peanut butter, baby. And we need to make a freaking Reese's cup. Okay.
Yes, I just had a Reese's Blizzard last night. It was delicious.
Oh, we can create a whole new paradigm, and orofacial myofunctional therapy training needs to come up with its own lexicon. We have to stop using speech terms or dental terms. We need to come up with a whole new lexicon so that everybody knows what we're talking about straight out of the gate.
I love that. I absolutely love that. I love your energy. I love your passion. I just think you're fabulous, Beth. So
Ah,
I appreciate you taking the time and coming and chatting with me about all of this. It is just so important. And I appreciate your, effort in getting this awareness out to, registered dental hygienists, because it's just so important.
it is important.
Well, thank you for coming on. We'll definitely
You're
have to have you back on
welcome.
again.
I can't wait to see you again, and I hope we see each other in person sometime really soon.
Oh my God. Yes.